Hi there to those of you who have joined over the phone. We're going to get started in just about 4 minutes. All right, we're going to go ahead and get started. Welcome, everybody, to the Rush Generations lecture on ovarian cancer. I'm Jasmine Chandy. I'm a program coordinator with Rush Generations. And for those of you who may be new to Rush Generations, or this might be the first lecture you've joined, welcome. We're so happy to have you. Rush Generations is a free health and wellness program that's all aimed towards aging as best as we can. So we have tons of great programs that are all virtual now. So we have fitness classes, lectures like this one, workshops, support groups, and tons of great activities to get involved in. And so we'll be talking a little bit more about that towards the end of the lecture. But just to get us started, a few notes. And let's see if I'm able to, let's try this again. There we go. So throughout this lecture, if you have any questions for our speaker, you can leave them in the YouTube chat box. So if you're on your computer, you'll see it right to the side, exactly as you see on the screen right now. And so you can type in any questions or comments you have throughout the lecture. Then at the end of the lecture, I'll share them with our speaker. And we'll have time for a Q&A at the end. So throughout the lecture, if you're on your computer, you're going to see it on the right side, just like it is on this slide. But if you've joined on a tablet or on your phone on YouTube, then you'll see that exact same box, but it'll be under the video. So either way, if you have any questions, go ahead and add them to the chat box. And for those of you who have joined over the phone, we will have an opportunity for you to share your questions at the end of the lecture as well. So any questions, please do type them in and we'll be able to share them with our speakers. And then at the end of the lecture, we will be talking a little bit more about some of our upcoming programs. But we're going to go ahead and get started and welcome our speaker for today. Margaret Wilson Dolan has been a physician assistant in gynecologic oncology at Rush University Medical Center since 2012. She received a Bachelor of Science from the University of Michigan and a Master of Medical Science from the Northwestern University Feinberg School of Medicine. She is dedicated to providing patient-centered care to women throughout their cancer journeys and appreciates the unique relationships she is able to form with her patients and their families. She is originally from Southeast Michigan and currently lives in Oak Park, Illinois, with her husband. Outside of work, she enjoys traveling, reading, and crafting. We're very happy to have Margaret here with us today for the lecture. And so without further ado, welcome, and we're going to go ahead and get started.
All right. Thank you so much, Jasmine. Hopefully you can see and hear me okay. Thank you all so much for having me today. I'm very excited to talk to you about ovarian cancer. So a brief overview of what we'll be talking about today. We'll start by going over some anatomy, and we'll talk about a little bit about what is ovarian cancer. We will talk about some risk factors. We'll also spend a little time talking about cancer genetics, and then we'll go over the stages and symptoms of ovarian cancer, talk a little bit about assembling the best team to take care of ovarian cancer, talk about some treatment options, and then go over some support resources, and then a little bit about prevention and screening. And like Jasmine said, at the end, we should have time for questions, so I'm happy to answer any questions you might have. So getting started right away with anatomy. So the ovaries are the female reproductive organs in which the eggs and the female sex hormones, estrogen and progesterone, are produced. They are a pair of organs in the pelvis, one on each side of the uterus, which is the hollow pear-shaped organ where a fetus grows. Each ovary is about the size and shape of an almond. The ovaries are mainly made up of 3 different kinds of cells. Each type of cell can develop into a different type of tumor. Epithelial tumors start from the cells that cover the outer surface of the ovary. Germ cell tumors start from the cells that produce the eggs, and stromal tumors start from the structural tissue cells that hold the ovary together and produce the female hormones estrogen and progesterone. Most ovarian tumors are epithelial cell tumors. And from this point forward, all the information I will be covering in today's presentation is referring to epithelial ovarian cancers. So what is ovarian cancer? Cancer starts when cells in the body begin to grow out of control, or they begin to divide without stopping. Cells in nearly any part of the body can become cancerous and can spread. Some ovarian tumors are benign or non-cancerous, and they never spread beyond the ovary. Tumors that are malignant or cancerous, or also ones that are borderline or called low malignant potential, can spread or metastasize to other parts of the body, and they can be fatal. Many people use the term ovarian cancer as an umbrella term, not only to include ovarian cancer, but also cancers that start in the fallopian tube and primary peritoneal cancer. We do feel that all 3 of these cancers are really sort of the same clinical entity. They act the same, and we do treat them the same. And interestingly, ovarian cancers were previously believed to only begin in the ovaries themselves, but a lot of recent evidence is suggesting that many of these cancers may actually start in the cells at the tips of the fallopian tubes. And that is an area that's currently undergoing a lot of research. So looking at gynecologic cancers in the United States, the most common is actually endometrial cancer, then followed by ovary, then cervix, and then vulvar cancer. However, the most deadly of the gynecologic cancers is ovarian cancer. Compared to other cancers in the United States, the ovarian cancer is relatively rare. It is the 17th most common type of cancer overall, and it is the 9th most common type of cancer in women. It is the 13th most common cause of cancer death overall, and it is the 5th most common cause of cancer death in women. This chart shows the estimated new case numbers for 2020 for the 10 most common types of cancer. And you can see on the bottom that ovarian cancer is the 17th most common and has an estimated new number of cases for 2020 of 21,750. There's an estimated number of deaths in 2020 of 13,940. Ovarian cancer represents only about 1.2% of all new cancer cases in the United States. About 48.6% of people who are diagnosed with ovarian cancer will survive 5 years or more. This relative survival is an estimate of the percentage of patients who would be expected to survive the effects of their cancer. It excludes the risk of dying from any other causes. It's important to remember that because survival statistics are based on large groups of people, they cannot be used to predict exactly what will happen to an individual patient. No two patients are entirely alike, and treatment and responses to treatment can vary greatly. In the United States, ovarian cancer is most frequently diagnosed among women ages 55 to 64. The median age of diagnosis is 63. It is most commonly diagnosed in white women, followed by Hispanic women, and then Asian and Pacific Islander women, and then Black women, and lastly, American Indian or Native Alaskan women. So next we'll move on to talk about some risk factors for ovarian cancer. There are many factors that can increase or decrease a woman's risk of developing this type of cancer. Some things that might increase the risk include a family history of breast, ovarian, or colon cancer, having a genetic mutation like BRCA, which we will talk more about in a couple minutes, being at an increased age, and being postmenopausal. Some things that could decrease your risk include pregnancy, breastfeeding, and the use of oral contraceptive pills. Research suggests that there is a relationship between the number of menstrual cycles, or the number of times that ovulation occurs in a woman's lifetime, and her risk for developing ovarian cancer. So a woman might be at increased risk if she had started menstruating at an early age, like before 12, has not given birth to any children, had her first child after the age of 30, experienced menopause after the age of 50, or has never taken oral contraceptive pills. All of these things would put you at a risk of having more numbers of cycles or more occurrences of ovulation in your lifetime. So next we'll talk a little bit about cancer genetics, which is a really exciting field in oncology right now. So cancer is the result of accumulated mutations in DNA, which can be either inherited or acquired. Genetic changes that promote cancer can be inherited from our parents if the changes are present in the germ cells, the eggs or the sperm. Such changes, called germline changes, are found in every cell of the offspring. Cancer-causing genetic changes can also be acquired during one's lifetime as the result of errors that occur as cells divide, or from exposure to carcinogenic substances that damage DNA, such as certain chemicals in tobacco smoke and radiation, such as ultraviolet rays from the sun. Genetic changes that occur after conception are called somatic or acquired changes. Overall, only about 5 to 10% of cancers are inherited. Ovarian cancer is usually not inherited. However, up to about 24% of cases may be related to inheriting a genetic mutation, even if the family history does not include ovarian or breast cancer. For that reason, it is critical for a woman to have a discussion with her healthcare team about her genetic predisposition to ovarian and other types of cancer at the time of diagnosis. The National Comprehensive Cancer Network, called NCCN, which is the organization that puts out many of our oncology guidelines, does strongly recommend that all women with ovarian, fallopian tube, or peritoneal cancer undergo genetic counseling and testing. Some of the more common inherited genetic syndromes that could increase your risk for ovarian cancer include the BRCA1 and 2 mutations and Lynch syndrome. BRCA1 and 2 mutations are the most common cause of hereditary breast and ovarian cancer. These genes are responsible for repairing damage to DNA, a routine process that occurs in all cells. While the average American woman has a less than 2% risk of developing ovarian cancer, a woman with a BRCA mutation could have up to a 40% chance risk of developing it. Lynch syndrome is a hereditary colorectal and uterine cancer condition, which can also increase the risk for ovarian cancer. Women with Lynch syndrome have about a 12% lifetime risk of developing ovarian cancer and a 40 to 60% chance of developing a uterine cancer. So this chart shows the estimated risks for cancer with patients who have a BRCA mutation. So they can be at a higher risk of breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, colon cancer, or melanoma. This chart shows the estimated risks for cancer of somebody with Lynch syndrome, which includes ovarian cancer, uterine cancer, and colon cancer. In addition to testing for inherited gene mutations, it is now becoming very common to have testing of the cancer or the tumor itself, which is called somatic testing, to check for any mutations that may indicate a patient will respond well to a targeted treatment option. Precision medicine, also called personalized medicine, is an approach to patient care that allows doctors to select treatments that are most likely to help patients based on a genetic understanding of their disease. This idea is not new, but recent advances in science and technology have helped speed up the pace of this area of research. We'll talk a little bit more about some targeted treatment options later in the lecture. So moving on to talk about the stages and symptoms of ovarian cancer. There are 4 stages. Stage 1, early disease, to stage 4, more advanced disease. This graphic shows how in stage 1, cancer is confined to one or both of the ovaries. In stage 2, the cancer has spread within the pelvic region. Stage 3, the cancer has spread within the abdomen. And stage 4, the cancer has spread beyond the abdomen to other body parts. The most common stage that we find ovarian cancer at is a stage 3C. Ovarian cancer often causes no obvious symptoms in the early stages, so it is most often found at an advanced stage. If women do experience symptoms, they can be very vague, such as bloating, feeling full quickly after eating, abdominal or pelvic pain, changes to your bowel habits, such as diarrhea or constipation, or changes to your bladder habits, such as urinating frequently or feeling a strong urge to urinate. Women who have had these symptoms almost daily for more than a few weeks should see their doctor, preferably a gynecologist. Prompt medical evaluation may lead to detection at the earliest possible stage of the disease. Early stage diagnosis is associated with an improved prognosis. All right, next I'll move on to talking a little bit about assembling the best team to care for an ovarian cancer. Seeking a specialist. If you suspect or have been diagnosed with a gynecologic cancer, such as ovarian cancer, it is very important to see a gynecologic oncologist. These are doctors with specialized training in treating gynecologic cancers who can manage your care from diagnosis to the completion of treatment. Gynecologic oncologists both perform surgery and manage chemotherapy. This photo shows one of our gynecologic oncologists here at Rush, Dr. Ahmed. We do have data showing that women who have their gynecologic cancers treatment overseen by a gynecologic oncologist do have higher cure rates than women who are treated by any other type of doctor. I'd also like to talk about second opinions. When you are facing a cancer diagnosis and treatment, it's very normal to wonder if another doctor could offer more information or a different treatment option. Getting a second opinion can help you feel more secure about your diagnosis and treatment plan. It is always best to seek a second opinion at an academic medical center. This is especially important if your initial diagnosis was based on a biopsy done at a local hospital. Sometimes when we have pathology re-reviewed here by our specialty pathologist, it can actually change the diagnosis. So very important. Some people do find it hard to tell their doctors that they would like a second opinion. Remember, this is a very common request, and no good doctor will ever be upset or offended when you ask for this. And they likely can recommend someone for you to see. There's a lot of team members you'll meet on your ovarian cancer journey. They usually will include a gynecologic oncologist, sometimes also a medical oncologist or radiation oncologist. Often there will be advanced practice providers such as PAs and nurse practitioners, oncology nurses, patient navigators, oncology pharmacists, palliative care specialists, genetic counselors, dietitians, pathologists, radiologists, mental health providers, chaplains, social workers, and financial counselors. And this is by no means an exhaustive list, but there's going to be a lot of people in your corner. So moving on to talk a little bit about treatment options. Ovarian cancer is most often treated with surgery and chemotherapy. Whether surgery or chemotherapy is used first will depend on several factors specific to your disease. For example, if there is a very high disease burden or something that would make surgery higher risk, such as a recent blood clot, then chemotherapy might be recommended first to shrink the cancer before proceeding to surgery. Only rarely is radiation therapy used, especially in the first-line treatment. We do sometimes use radiation therapy if the cancer has come back and is causing pain in a particular area. Surgery is usually the first step in treating ovarian cancer and should always be performed by a gynecologic oncologist. Most surgery is performed using a procedure called a laparotomy, during which the surgeon makes a long incision in the wall of the abdomen. Occasionally, early-stage ovarian cancer may be managed by laparoscopic surgery, where multiple small incisions are made in the belly button or lower abdomen. If ovarian cancer is found, the gynecologic oncologist usually performs several procedures, including removing the fallopian tubes and ovaries, which is called a bilateral self-oophorectomy, and is quite a mouthful. They will generally also remove the uterus and the cervix, which is called a total hysterectomy. They will also generally perform a staging procedure where the omentum, which is a fatty pad of tissue that covers the intestines, is removed along with nearby lymph nodes and multiple tiny samples of tissues from the pelvis and abdomen. They will also perform a debulking or cytoreduction procedure. This is the removal of any additional visible disease. The goal of this surgery is to remove as much cancer as possible. Ovarian cancer likes to spread like mold on bread or like grains of sand, and it will coat many of the surfaces in the abdominal and pelvic cavities. So often this can involve extensive surgery to remove as much as we can. It could include removal of portions of the small or large intestine and removal of tumor from the liver, the diaphragm, and the pelvis. We do know that removal of as much of the tumor as possible is one of the most important factors affecting cure rates. If we are able to remove all the cancer that we can see, or remove anything that is greater than a centimeter, we call it an optimal debulking. If anything is left that is greater than 1 centimeter, we may call it a suboptimal debulking procedure. Most patients with ovarian cancer will also need chemotherapy. Chemotherapy is the use of drugs to kill cancer cells. Chemotherapy for ovarian cancer is usually given intravenously, injected into a vein. The drug travels through the bloodstream to reach all parts of the body, which is why chemotherapy can be effective in treating ovarian cancer that has spread beyond the ovaries. Carboplatin, or carbo, and paclitaxel, or Taxol, are very common first-line chemotherapy medications used for ovarian cancer. The same drugs that kill cancer cells can also kill healthy cells, which leads to side effects. Chemotherapy is usually given in cycles, for example, 1 treatment every 3 weeks. Most women with ovarian cancer receive chemotherapy for about 4 to 6 months following their surgery. In some cases, it may be appropriate to continue chemotherapy for a longer period of time to reduce the chance of the cancer returning. There are multiple different side effects from chemotherapy. Some of the most common can include fatigue, hair loss, and nausea or vomiting. We do have a lot of very good supportive medications to prevent nausea and vomiting these days, though. I'd also like to talk about clinical trials for a moment. There are many ongoing clinical trials studying new and better ways to treat ovarian cancer. Many treatment options are available today because women diagnosed with ovarian cancer were willing to participate in prior clinical trials. Clinical trials are designed to test some of the newest and most promising treatments for ovarian cancer. This is another great reason to consider getting a second opinion at an academic medical center, because generally clinical trials are only available at academic centers. So now talking about some targeted therapy options. There are many new treatments that are targeting specific mechanisms of tumor growth. For example, there are drugs that can block new blood vessel formation or target specific tumor enzymes that inhibit tumor growth. Many of these new agents are being investigated currently in clinical trials. Because these drugs block pathways that are more active just in tumor cells, they are often not as damaging to normal cells. Sometimes these targeted therapies are combined with chemotherapy to try to make the chemotherapy more effective. So this comes back to what I mentioned previously about precision medicine and this idea of using treatments that are targeted to a specific mutation rather than a specific type of cancer. One example of targeted therapies that many of you may be familiar with is a drug called Keytruda or pembrolizumab. There's a lot of TV commercials for this one, and it's also the medication that Jimmy Carter received for his melanoma. This is a treatment that we do sometimes use in gynecologic cancers as well, but it's also commonly used in lung cancer and melanoma as well as others. So following up after treatment. In general, women are followed closely with exams, including a pelvic exam, every 3 months for at least 2 to 3 years. And then we extend out a little less often, about every 6 months, until about 5 years from the end of the treatment. Then they can go back to once-a-year visits. It is very common to have a CA-125 blood test, which is a tumor marker blood test that's commonly elevated in ovarian cancer, checked at each visit. In addition, imaging studies such as CT scans may be periodically performed, and especially would be ordered if you had any new pains or symptoms. Unfortunately, despite initial therapy, the majority of women with an advanced stage ovarian cancer will relapse and require additional treatment. There are many treatment options for recurrent disease, usually chemotherapy or targeted therapies. Recurrent ovarian cancer is generally not considered to be curable, but it is very treatable. We often say that we can manage it like a chronic disease. So moving on to talk about some support options. There are a lot of impacts of a cancer diagnosis and treatment. It affects much more than just the organ involved. There is typically a vast and persistent impact of both the diagnosis and the treatment of a cancer on the adult survivor's physical health, mental state, their health behaviors, their professional identity, their personal identity, relationships, sexuality, and financial standing. Integrative therapies can often enhance your treatment by reducing the mental and physical stresses that often accompany traditional treatments. For example, here at the Rush Cancer Center, our supportive oncology team offers psychologists who specialize in cancer patients and their families, chaplains, acupuncture, massage therapy, dietitians, social workers, financial counselors, and palliative care providers. I like to take a minute to just talk about palliative care and hospice, because sometimes these are terms that can be very scary for people. Palliative care is a specialty that focuses on relieving symptoms that are related to chronic illnesses. This is something that can and should be practiced along with disease treatment like chemotherapy and is appropriate at any stage of cancer. The goal of palliative care is to prevent or treat as early as possible the symptoms of cancer, as well as treat the side effects caused by life-prolonging treatments of cancer. Palliative care also addresses the psychological, social, and spiritual problems related to cancer or its treatment, thus providing patients with whole person care, not just care of their cancer. It is ideally to integrate palliative care early in the disease process, and many studies have actually shown longer survival when this is done. Hospice care is a subset of palliative care practiced at the end of life. Some people feel like when we start discussing hospice care that it means there's nothing more we can do or that we will stop taking care of you. And I want to reassure you that that's not the case. Moving towards hospice care is when we shift our goals towards optimizing quality of life remaining when curative treatment is no longer desired or beneficial. Hospice services can be provided in the patient's home or in a specialized facility. I'd also like to talk a little bit about caregivers, as I understand we may have some caregivers in our audience today. Cancer affects not only the person diagnosed, but all those who care about that person. The following are some tips intended to help caregivers tackle the challenges of caring for somebody with cancer. This list comes from the Foundation for Women's Cancer website, which is a great resource. So we recommend to find your support system, gather information and keep records, recognize that this is a new normal, take the time to relieve your mind and recharge your body, take comfort in others, plan for the future. It can often be much easier to have difficult conversations with your family member when things are calm and they're feeling well, rather than waiting for an emergency situation. Accept help when it's offered, be mindful of your own health, consider exploring stress management techniques, and do what you can, but admit that you can't, or admit what you can't. So finally, moving on to some screening and prevention information. Screening tests and exams are used to detect a disease like cancer in people who don't have any symptoms. Some common cancer screening tests include mammograms, which can often detect breast cancer in its earliest stage, even before a doctor can feel the cancer. Pap smears, which can find abnormal cells in the cervix, which may turn into cancer. And colonoscopies, which can find precancerous polyps so that they can be removed before they turn into a colon cancer. There has been a lot of research to develop a screening test for ovarian cancer, but unfortunately there has not been much success so far. Better ways to screen for ovarian cancer are being researched, but currently there are no reliable screening tests available. Hopefully, improvements in screening tests will eventually lead to fewer deaths from ovarian cancer in the future. If you are at average risk, there are currently no recommended screening tests for ovarian cancer for women who do not have symptoms and are not at a high risk of developing ovarian cancer. In studies of women at average risk of ovarian cancer using transvaginal ultrasound and the CA-125 blood test for screening have led to more testing and sometimes to more surgeries, but they did not lower the number of deaths caused by ovarian cancer. For that reason, no major medical or professional organization currently recommends the routine use of transvaginal ultrasound or the CA-125 blood test to screen for ovarian cancer in women at average risk. If you are at high risk, some organizations state that the transvaginal ultrasound and CA-125 blood test can be offered to screen for women who are at a higher risk of developing an ovarian cancer due to an inherited genetic syndrome such as the BRCA gene mutations or a strong family history of breast and ovarian cancer. Still, even in these women, studies have not proven that using these tests for screening lowers their chances of dying from an ovarian cancer. Some risk factors for ovarian cancer, like getting older or having a family history, cannot be changed. Some women might be able to lower their risk slightly by staying at a healthy weight or not taking hormone replacement therapy after menopause. It is always important to have regular well visits with your medical providers and to know your family history and share it with your doctors. We do know that women who are at high risk for ovarian cancer due to a genetic mutation and have surgery to remove their fallopian tubes and ovaries can decrease their risk of developing an ovarian cancer by more than 80%. This procedure is called a laparoscopic BSO, or laparoscopic bilateral salpingo-oophorectomy, and just means the removal of tubes and ovaries through small incisions. This is an outpatient procedure that's generally very well tolerated. You may be familiar with risk-reducing surgery because several years ago, Angelina Jolie had surgery to remove her breasts, her tubes, and her ovaries because she tested positive for the BRCA1 gene, and there was several news articles about it. So lastly, I'd like to leave you with some resources if you're interested in reading more. Like I mentioned already, the Foundation for Women's Cancer is an excellent website with very good information. The American Cancer Society also has great information about many different types of cancer. Bright Pink is an organization that aims to educate younger women specifically about their breast and ovarian health. The National Ovarian Cancer Coalition, the Society for Gynecologic Oncology, and the National Comprehensive Cancer Network are also excellent resources, as well as the Centers for Disease Control, the United States Preventative Services Task Force. If you're interested specifically in statistics about cancer, the SEER website, which stands for the Surveillance, Epidemiology, and End Results Program of the National Cancer Institute, is a great resource. And finally, the website Up to Date has lots of great information about lots of different health topics. So with that, I'm happy to answer any questions.
Thank you so much. That was great. We really appreciate you speaking for us. That was so wonderful also to not only talk about anatomy and ovarian cancer in specifics, but also talking about the support and how normal that is, and also debunking some of those terms for us. So we thank you so much. For our participants, again, if you have any questions, you can continue to add them to the YouTube chat. We have a few questions for you already, but before we read those, I just want to offer this time for anyone over the phone. If you have any questions, you can unmute yourself now and ask your question. Hi, did you have a question? Yeah.
Oh, yes. So I got in a little late. So were there symptoms for getting or not getting, if you have ovarian cancer?
Sure. Symptoms to watch for or to notify your doctor about could include bloating, feeling full more quickly after eating, changes in your bowel habits or urinary habits, or pelvic or abdominal pain, especially if those symptoms have been noticed daily for more than a couple weeks.
Okay, so can, okay, I don't know how to say this one. Okay, so okay, how do you test to see if you have it, if you have ovarian cancer? How do they test that?
Sure, that's a great question. So if you have any symptoms and talk to your doctor, they may recommend starting with a pelvic ultrasound to evaluate if the ovaries look normal. And then if there's any concerns on that, then they may refer you to a specialist. Sometimes we do other tests like CT scans. Ultimately, to diagnose an ovarian cancer, we need tissue pathology, either from a biopsy or a surgery.
Okay. Okay, thank you.
Yeah.
Thank you for your question. And anyone else over the phone? Does anyone else have any questions? All right, so we're going to have another opportunity for those of you on the phone in a few minutes, but I'm going to go ahead and read some of the other questions we had online. So the first question, are ovarian cysts indicative of future ovarian cancer?
That's a great question. And the answer is not always no. It is a very normal part of the menstrual cycle to have for the ovaries to make a cyst every month. In women who are after the age of menopause and not going through the monthly menstrual cycles, then it's much less common to have ovarian cysts. And we generally would watch those if they were getting larger, or especially if they had any solid components or looked worrisome on the imaging, then we might recommend a surgery to evaluate them further.
All right. The next question, could ovarian cancer be detected from a blood test?
That's a great question too. So unfortunately, the research has shown that using that CA-125 blood test as a screening test is not very helpful. We know that it can be useful in the setting of somebody who we know already has an ovarian cancer, and then to follow it throughout treatment and in surveillance, but it's not very helpful as a screening test. And there's really no other blood tests that have been proven to be helpful in screening for ovarian cancer.
All right. And then is ovarian cancer screened for during a yearly physical?
Another good question. So having an annual physical is very important. It can not only help detect any problems, but it helps to make sure that your provider knows you and you kind of your baseline well. And so that if there's any changes, they can, you quickly have somebody that you're able to talk to about it. We do recommend having an annual pelvic exam. But again, it's not been proven as a screening method specifically for ovarian cancer, but it can often pick up if there's anything out of the ordinary. So we do recommend it.
All right, great. And then this last question is the same question actually that the person over the phone had asked. So it's a good question because more people are thinking about it. But if you could just reiterate or share it again, what symptoms are red flags that you might have ovarian cancer?
Yeah. So the thing about ovarian cancer that's tough is many of these symptoms we only notice sort of later after we know that the cancer's there. Then people can sort of retrospectively reflect and say, oh, I did notice, these changes. But they're often very vague. And especially as women, we're used to kind of just getting things done and pushing through. And so often, we don't pay attention to them. But things to watch for would be bloating, pelvic or abdominal pain, if you feel full more quickly after eating than typical, changes in the bowel movements or the urinary habits, or anything that kind of doesn't seem normal for you. And especially if those things are present, almost daily for more than a couple weeks, you should definitely speak to your healthcare provider.
Great. And those were all of our questions online. But before we move forward to share some of our upcoming events, just want to offer one last opportunity for those of you who are on the phone. If anyone has any questions, you can unmute yourself now and ask your question.
Okay. Hello?
Yeah, go ahead.
Okay. So the frequent urinary, I mean, isn't also that you get that as you get older anyway? So
you can. There's lots of other conditions that can also cause frequent urination. So I would just speak to your healthcare provider and they can kind of evaluate what they think the most likely cause of that symptom would be.
Okay, so when you say the healthcare, so is that the gynecologist or your primary?
Yeah, either one would be a great place to start. Whoever, you have the best relationship with, who can give you the soonest to evaluate any new changes.
Okay, thank you.
Great question. Yeah. And also we had a lecture a few months ago on incontinence as you age. So if that's something you're interested in, we can definitely send you the slides to that lecture too. All right.
Okay.
All right. Sounds good. Thank you for your question. Did you have any other questions or anyone else on the phone? Any questions? All right, it looks like we're ready to move on. Thank you so much again for speaking for us. We really do appreciate it. And thank you to everyone on the phone and online for your questions and for joining us online. We're going to go ahead and share some of the upcoming programs that we have with Rush Generations. And so I'm going to go ahead and share my screen. All right, there we go. So first we have the chronic pain self-management workshop. This takes place on Mondays from October 26th until November 30th from 1 to 3:30 p.m. It will take place through Zoom, so that means that it'll be done through kind of like a video chat service online. And so if you're not familiar with Zoom or technology, that's okay. We're here to help with that. So if you're interested, you can still call to register, and then a member of our team will follow up with you to make sure you're all set and that you get comfortable using Zoom before the session. So if you're interested in the chronic pain self-management workshop, so that's a workshop learning about how to manage your pain and different tools for that, you can register by calling 800-757-0202. Again, that's 800-757-0202 for the chronic pain self-management workshop on Mondays from October 26th till November 30th. Next, we have our WRAP program. So this is a program, it's also a workshop, but it's geared towards our mental health and improving our health by using the skills that we have and building on the strengths that we have. So this will be on Thursdays from October 29th until December 10th. This is from 10:30 in the morning until noon. And this will also take place through Zoom. So if you're interested in registering, you can call that same number, or you can call Patrick Stanley actually for this one. And the number is 312-942-2089. And again, if you wanted assistance learning how to use the technology or getting comfortable with it before the workshop, we're here to help. So if you're interested in signing up for the WRAP program, that's on Thursdays from October 29th till December 10th from 10:30 in the morning till 12. You can register by calling Patrick at 312-942-2089. And lastly, we also have the Take Charge of Your Health workshop. And this is a workshop that's geared towards taking care of our chronic conditions. So learning about different ways to eat healthy and be active in a healthy way, in a safe way, and also making goals and figuring out how to accomplish those goals to improve our health. And so this workshop will be done entirely in Spanish. And it's going to be on Wednesdays from October 28th till December 16th from 9:30 in the morning till noon. And again, this is also done through Zoom, so all of our programs are done virtually. If you're interested in joining this workshop, you can call 312-942-2089. And again, if you're interested in any of these programs, but you're just not comfortable with the technology, that's not a problem at all. All you need is the interest, and then we'll help you with the technology piece to make sure you're comfortable before the first day. And lastly, just a reminder that Rush Generations is with you during social distancing. We have tons of great programs that are offered virtually. Again, we have more lectures just like this one. We have workshops, support groups, exercise classes, also opportunities to volunteer, wonderful opportunities that are all done virtually now just to stay safe. So if you're interested in learning more about these programs, or if you're feeling lonely and want to get connected, or if you have some other needs, we're here to help. So you can call the Rush Generations toll-free number at 800-757-0202. And then lastly, if you would like to receive our e-newsletter, so that means receiving emails when we have upcoming programs, you can sign up for that e-newsletter by typing in bit.ly rush generations, and the R and G is capital. So you can type that in to receive our e-newsletter. And if you wanted a copy of the lecture slides from Margaret Dolan, so if you wanted those slides in case you joined over the phone or just wanted a copy of it, we can definitely email you those slides or also mail it to you if you wanted a physical copy. So if you're interested in those slides, you can give me a call at 312-942-6995. And again, we can mail it to you to your house or email it to you. All right, and then before we end for the day, I'd like to show you one more program that you may have heard about before, and that's the Shaman Senior Voices program. So for those of you who may have joined our lectures in person earlier, you may have seen that kiosk with a big ring light and an iPad where we're able to record people. So I'd love to bring that up again because just like our other programs, this has also moved virtually. So the Shaman Senior Voices program is all about learning from older adults about what matters most as we age. We then use this information to improve the programs that we have and also to improve the way that we interact with and the services that older adults receive. And so the way that we do this is by recording videos from as many older adults as possible around the topics of what matters most as you age, what do you like about aging, and similar questions, and recording a video in just 60 seconds or so just about a minute. And then we then use these videos to educate the healthcare students, also having discussions with physicians and other healthcare providers, and then having conversations about aging. So expanding this conversation on aging. And so if you go to aging.rush.edu/shaman, so that's SCHAALMAN, you'll be able to see the Shaman Senior Voices page. And so here you can read a little bit more about the program. And there's also tons of great resources here to get involved with. So there's some videos here where you can learn a little bit more about who Rabbi Shaman was and why the program is named after his legacy. There's also some video clips of his teachings. There's some videos of other older adults in the community sharing their perspectives on aging, as well as videos from students sharing their perspectives. And so I'd love to show you right here some of the videos that we have collected from older adults all around the community. And so here there's a bunch of them. You may recognize some faces and you may not. But again, really just trying to learn what's most important to you and what matters to you as you age. And especially this time of COVID where everyone is staying home, it's been an uninvited time, but a good time to reflect on what matters most to us. So we would encourage you to record a video if you feel comfortable. If you go to the website, again, that's aging.rush.edu/shaman, and you scroll all the way to the bottom, there's a section called Collaborate and Connect. So once you go to Collaborate and Connect, it's going to guide you on how you can record your own video. So the nice thing is you can do this in the comfort of your own home whenever you're ready, and share with us what matters most to you as you age and how you're staying connected to what matters most to you right now. And if you have any questions about this, you can always give me a call again. My number is 312-942-6995. But if you're interested in getting involved with any of our programs, you let us know, and we look forward to seeing you at our next lecture.